Thank you for inviting me to speak today. My topic is on body mass composition. So body mass is not something that's new in the PICU. It's commonly used to calculate drug doses, to estimate ventilation requirements. And as a dietitian, I use body mass index all the time, or body mass, to assess the nutritional status of a patient. So what I'm going to try to do is present a little bit of the newer information that I have on body mass, talk a little bit about body composition, which I've been trying to study for the past 4 years, and link them all to the outcomes in critically ill children. So the reason why we're talking about body mass in the first place is because of the metabolic response during critical illness. And you can see that usually critical illness is associated with a hypermetabolic state, and there are increased energy requirements because of an increased energy expenditure. More so in adults than in children. But at the same time, there's also increased muscle protein turnover or protein turnover, where there's increased breakdown and increased synthesis of acute phase proteins. So bearing all of this in mind, if you have 2 patients presenting to you, everything, all else equal, you would think that the metabolic stress response would affect these 2 patients very differently, right? And something that we commonly use to look at the body mass status or body habitus is the body mass index. So this is basically the weight divided by the height in meters squared. Okay? So to help us in trying to classify certain patients and their nutritional status, we have something called healthy weight ranges, healthy BMI ranges. So you can see these are the healthy weight ranges in adults. There is a lower, or what we call underweight range, and then there are those who are overweight and then increasing rates of obesity. But in children, because the BMI is not stagnant across ages, there's actually a curve, and you can see that the BMI Z-score, what's considered acceptable, would change over time. So we classify children's BMI status using Z-scores. And basically, what is considered acceptable or normal is anywhere between -2 to 2. And then anything below that, we consider low. And anything above that, we consider high. So what are the BMI profiles of children that come into our PICU? This is data from all over the world. We have some from international data. So Bashard's Pediatric International Nutrition Survey 2 shows roughly most of the children have normal BMI Z-scores, about maybe 60 to 70% of them. And then there are some with low BMI Z-scores and some with high BMI Z-scores, and it really depends on which part of the world you are in. The French-speaking countries appear to be the leanest. The Americans appear to be of higher BMIs. And then in Singapore, what we find is somewhat similar to international data and similar to the French-speaking countries, where majority of our children are of normal BMI Z-scores, but we do see about 30% having low BMI Z-scores and about 10% having high BMI Z-scores. So traditionally, like I showed you the photo of the 2 cats in the beginning, the low BMI Z-score ones are those who have been thought to be at greater malnutrition risk, right? So this is a definition of pediatric malnutrition that has been used in Michigan. And you can see that anything below -2 is considered at moderate malnutrition risk, and then -3 is severe malnutrition risk. So looking at these, you would think that, okay, if my BMI was above 2 or above 1, I would be fine, right? I would be at low nutritional risk. And maybe that is true. So there's something called the obesity paradox in critically ill adults, right? Traditionally, if you think of obesity, you think of a greater risk of mortality in a normal state, in a non-ICU patient. So the adults have shown that there's this obesity paradox where if you are obese or have a high BMI, you're actually protected against mortality. So this is There are a lot of studies that have shown this, and this is one that's more recently published in Critical Care Medicine on 55,000 adults, critically ill adults with sepsis. And what they have shown, basically you can see in the picture on the left, the adjusted odds ratios. So the underweight have an adjusted odds ratio of about 1.6 for death. And if you are overweight and obese, you seem to have a lower risk for mortality. Yeah. So what about in children? There are studies that have looked at BMI z-scores and whether the obesity paradox occurs in children. So this is one study that have looked at mortality, and they did find that there was somewhat of an obesity paradox where those with higher BMIs, the obese children, were at lower risk of mortality, but only in children with indirect lung injury. But then there's also some that demonstrate, okay, it was not associated with reduced mortality, but it was associated with a decreased need for intubation and inotropic support. So maybe there's still this obesity paradox, but you can see that the evidence is not very consistent anymore. On the other hand, in the past few years, there are also several studies that have shown that obesity is also associated with increased risk of worse outcomes, and I'll take you through some of them. So, the first study by Numa and the group in Australia have shown that actually, this is using weight z-scores, there's a U-shaped curve for mortality. So, if you're on the extreme ends, you actually experience greater risk for mortality. And this was, again, replicated in another study more recently that showed in red would be the line for the BMI z-score and the risk of mortality. So actually, it appears that it's not good if you're too underweight or too overweight. What about for ventilator dependence? So similar, you can see on the left would be those with direct lung injury, on the right with indirect lung injury. And you can see there is a clear separation of lines for the indirect lung injury group, where the overweight patients appear to have somewhat greater risk for ventilator dependence or prolonged ventilator dependence. There's also some signal for those with the obese, but that was not statistically significant. But this gives an idea that perhaps the mechanism of injury can also depend. So it's not a uniform risk that we see across the entire group. So it may depend on the injury mechanism. What about for PICU and hospital stay? So same thing. For both PICU and hospital stay, we see that those who are at low BMI and at high BMI appear to have a greater risk compared to those of normal BMI. And then what our group did at our PICU was to look at functional impairment. Now, functional impairment is something that has been increasingly discussed or mentioned in pediatric studies. And what we did was to look at their functional status at baseline, at PICU discharge, and then when they're discharged from the hospital. So we measured something called their functional status scale scores. This is like a global functional assessment score. And what you can see is that the rates of functional impairment were higher in those with high BMI, and that persisted at hospital discharge. Similarly, in the low BMI group, that it was also higher than those with normal BMI. The same thing for resource utilization. Those who were underweight appeared to need more parenteral nutrition and tube feeding, which is not surprising because we typically think, okay, these are the group which are at greater malnutrition risk. But in terms of the overweight and obesity, we also see that they have increased need for ECMO and CRRT. So this is a study on sepsis patients, and they looked at the overweight and obese children. They found that even though there was no significant difference in the etiology of sepsis, which is the figure on the left, they did have greater need for ECMO and CRRT. So, bearing all of these in mind, I think we really don't know why this is what we're observing, there are some hypotheses in why these are why we are seeing what we're seeing. So for the low BMI group, first of all, they come in with low body stores, and that's something that's quite intuitive. We think because they have low body stores, they have less of a buffer to help to protect them against any risk of underfeeding, malnutrition, critical illness, myopathy, catabolism. But also BMI might be an indicator of a pre-existing poor underlying health. So if they have certain conditions that are associated with malnutrition, they may also be at greater risk of poorer outcomes when they're admitted into the ICU. And what about the high BMI groups? So when you think of high BMI, you think of adipose tissue or fat. And adipose tissue tends to be pro-inflammatory, can possibly increase the inflammatory response that is seen during critical illness. In those who are overweight and obese, we tend to see a bit more of metabolic alterations at the same time. They are at greater risk of insulin resistance, or they have hyperglycemia. In ventilation too, when you have somebody with higher BMI, it might be a bit more difficult to estimate ventilation requirements, especially things like tidal volume and PEEP and adjusting like that. There might be lower perfusion to the vital organs, but I think what has drawn me to this topic is possibly what kind of muscle changes if these children, because they are of higher BMI, they have accelerated muscle loss. And unfortunately, from the data that we have, I cannot tell, right? That's because if you look at BMI, it is just a very crude estimation of your body composition. We think that having high BMI means having high fat or maybe high muscle mass, but we really don't know, right? Because weight can be due to fat, it can be due to bones, it can be due to muscle, fluid, anything. So this is a picture of the adults. On the left, you can see two men of the same BMI, same height, same weight, but they have very different body composition, right? Fat percentage is different. Their resting energy rate is also different. And on the right are some CT scans that have been conducted in adults. So you can see that they are of increasing diameter or circumference, and that would indicate a greater BMI. But you can see what they have drawn out in red is the skeletal muscle, and in yellow is the visceral adipose tissue. That's the adipose tissue within the organs or surrounding the organs. And you can see that in the smallest patient, skeletal muscle was not necessarily that much lower than that of the obese patient or the highest BMI patient, right? So we really need to know about the body composition of these patients. And that's what some of the adults did, and this is Peter Weiss and his group. What they looked at was the skeletal muscle on CT scans of the third lumbar vertebrae. They correlated the skeletal muscle area, and they looked at those with high skeletal muscle and low baseline skeletal muscle. So these were baseline CT scans. And what they did find was that those with a lower skeletal muscle, when they came in, they were at greater risk for mortality. And that the skeletal muscle area was a more sensitive indicator of mortality risk than just BMI alone. And apparently, it's not just the skeletal muscle mass or the size, it's also the quality. So when you look at quality of the muscle, you're able to measure that using the skeletal muscle density or the infiltration of intramuscular adipose tissue. So intramuscular adipose tissue, if you look at the picture, is in green. It's the muscle, the fat that is within the muscle, and that compromises on the muscle structure. And what they found was that having greater intramuscular adipose tissue was associated with a greater risk of mortality too. So, what about in children? Sorry. Next slide. Okay. Yeah. Oh, I'm pressing the wrong one. I'm sorry. Sorry. Okay. So this is what we did in our children. So we also wanted to do the same thing. We looked at the CT scans of those who were admitted, the baseline CT scans of those children who are admitted into our PICU. And what we saw was that there were very visible differences. I didn't highlight it here in the picture, but if you take a look at the top two pictures, those are children with high BMI Z-scores, right? But if you look closely at the skeletal muscle area or the size, you can see that the one on the left has a greater skeletal muscle area compared to the one on the right, even though they both have high BMIs, right? And in those with low BMI, so those are the bottom two pictures, low BMI Z-score, we saw different levels of visceral adipose tissue, which is the adipose tissue that's within the organs or surrounding the organs. So the space in between would show the visceral adipose tissue, and the one on the right had a greater amount of visceral adipose tissue than the one on the left. So BMI alone doesn't tell you all these things like skeletal muscle or visceral adipose tissue. And what we wanted to try to find out is how do these skeletal muscle or visceral adipose tissue areas correlate with the outcomes. So these are predicted probability curves, right? On the left, you see the predicted probability of persistent functional impairment at hospital discharge with increasing skeletal muscle index, which means that if you follow the red line would be the ones with the persistent impairment, which means they have impairment at ICU discharge and also at hospital discharge. And you can see that as the skeletal muscle index increases, the risk of this persistent functional impairment also increases. And then on the right is the predicted probability curve for visceral adipose tissue index. So the reason why we looked at visceral adipose tissue is because we found that among all the different adipose tissues, whether it is subcutaneous, intramuscular, or visceral, the visceral adipose tissue was the most correlated with outcomes, or the greatest R squared. So we included visceral adipose tissue. And what you can see is that with increasing visceral adipose tissue, there's also an increasing risk of persistent acquired impairment. So I think this is a little bit contrary to what the adults have shown, where they saw that lower skeletal muscle at admission was associated with a greater risk of poorer outcomes, and we demonstrated that higher skeletal muscle was associated with worse outcome. So why is this so? I don't really know, but perhaps it might be an explanation for all the differences that we are seeing in BMI. I think the missing part or the missing piece to this puzzle is really what are the longitudinal changes in muscle or body composition, whether it's fat or muscle, in these children. So in adults, we've seen, this is data published by Puducherry in JAMA in 2013 on the left. And rectus femoris, what they did was they measured the rectus femoris cross-sectional area using ultrasound. So that's one of the quadriceps muscles. And they saw that the cross-sectional area decreased with time in the ICU. And more recently, Johnson and his group published something similar that has been seen in children. So this is quadriceps muscles of the children. And you can see that overall, in this is first 7 days of ICU stay, there's a decrease in the quadriceps muscle area. And this seems to increase with age. So the older you are, the more loss you experience. So I think that brings me back to BMI alone and how BMI cannot tell us this picture, right? So talking about all this, I think the question is really what do we do then with nutrition and what's the implication of these on nutritional practice? I think moving forward, there's a greater role for imaging or estimation of body composition or assessments of body composition somehow. We know that CT and MRIs are actually not a very good way to look at body composition in children because we don't put them under unnecessary radiation or it requires very specialized equipment, specialized personnel, and takes a long time. Maybe muscle ultrasonography, which can be done at bedside, and they have increasing new technologies to look at what is in the muscle, including glycogen, and perhaps it is looking at other things like bioelectrical impedance analysis. So that can be used to look at the health of the muscle, health of the cells, things like phase angle are used, or maybe even back to the usual skin folds, but that can be technically difficult in the ICU with patients who are supine and lying there and unable to turn and unable to get it accurately. But ultimately, I think it's combining these body composition changes longitudinally and combining that with nutritional provision and using those to look at what are the outcomes in these children, how we can improve the outcomes of these children in terms of nutritional practice. So that's all I have. Thank you.